Management of the common cold and its complications. The management of the common cold consists primarily of supportive care and anticipatory guidance. When we see supportive interventions, maintaining adequate oral hydration may help to prevent dehydration and to thin secretions and soothe respiratory mucosa. The common home remedy of ingesting warm fluids might soothe mucosa, increase nasal mucosa flow, or loosen respiratory secretions. Topical nasal saline might temporarily remove secretions, and the saline nasal irrigation might reduce symptoms. The use of oral non-prescription therapies, mainly containing antihistamines, antitussives, and decongestants for cold symptoms in children is controversial. It is used in adults, but for children it is not well studied. Because young children cannot participate in assessment of symptom severity, so study of this treatment in children have generally been based on observation by parents or other observers. Because of the lack of direct evidence for effectiveness and the potential for unwanted side effects, it is recommended that non-prescription cough and cold products not be used for infants and children younger than 6 years of age. Zinc given as oral lozenges to previously healthy patients reduce the duration but not the severity of symptoms of a common cold. It reduces the duration but not the severity if it began within 24 hours of symptoms. But this zinc have some side effects such as decreased taste, bad taste, and nausea. This can be reduced by taking a reduced amount of or a reduced dose of zinc. So taking zinc 5 to 10 milligram daily is so effective with reduced side effects. The things that should be managed in a common cold is fever. Fever is not usually associated with a complicated common cold, and antipyretic treatment is generally not indicated. Non-steroidal anti-inflammatory drugs might decrease discomfort from cold-related headache or myalgia. The other is nasal obstruction. Either topical or oral adrenergic agents might be used as nasal decongestants in older children and adults. Effective topical adrenergic agents such as xylometazoline, oxymetazoline, or phenylephrine are available as either intranasal drops or nasal sprays. Reduced strength formulation of these medications are available for use in younger children, although they are not recommended for use in children younger than 6 years of age. Systemic absorptions of imidazolines has very rarely been associated with bradycardia, hypotension, and coma. Prolonged use of topical adrenergic agents should be avoided to prevent the development of rhinitis medicamentosa, which is an apparent rebound effect that causes the sensation of nasal obstruction when the drug is discontinued. So, xylometazoline, for example, should not be used continuously for more than 5 days because it can cause rhinitis medicamentosa, which is a rebound sensation of nasal obstruction. The oral adrenergic agents are less effective than the topical preparations and are occasionally associated with systemic effects such as central nervous system stimulation, hypertension, and palpitation. Pseudoephedrine might be more effective than phenylephrine as oral agent to treat nasal congestion. The other is rhininos or rhinorrhea. The first generation antihistamine might reduce rhinorrhea by 25 to 30%. The effect of the antihistamine on rhinorrhea appears to be related to the anticholinergic rather than the antihistaminic property of these drugs. And so, the second generation or non-sedating antihistamine have no effect on common cold symptoms because they don't have effect on as anticholinergic. The first generation antihistamine have some anticholinergic effect. The major adverse effects associated with the use of antihistamines are sedation or paradoxical hyperactivity. Overdose might be associated with respiratory depression or hallucination. Rhinorrhea may also be treated with ipratropium bromide, a topical anticholinergic agent. So you can nebulize ipratropium bromide, and you can also give as a topical treatment. The most common side effects of ipratropium are nasal irritation and bleeding. The other is sore throat. The sore throat associated with colds is generally not severe, but treatment with mild analgesics is occasionally indicated, particularly if there is associated myalgia or headache. Aspirin should not be given to children with respiratory infection because of the risk of Reye syndrome in children with influenza. Non-steroidal anti-inflammatory drugs and acetaminophen are somewhat effective in relieving discomfort caused by cold, but there is no clear evidence of an effect on respiratory symptoms. The other is cough. Cough suppression is generally not necessary in patients with cold. Cough in some patients appear to be from upper respiratory tract irritation associated with postnasal drip. Cough due to postnasal drip is more prominent during the time of greatest nasal symptoms, and the treatment with first generation antihistamine might be helpful. Cough lozenges or hard candy might be temporarily effective and they are likely to be harmful in children for whom they do not pose risk of aspiration. So cough lozenges or hand candy can be given to reduce cough for those greater than 6 years. Honey, 5 to 10 ml for more than 1 year can also decrease nocturnal cough. They have modest effect on relieving nocturnal cough and it's unlikely to be harmful in children older than 1 year. As you know, honey should be avoided in children younger than 1 year because of the risk of botulism. In some patients, cough might be a result of virus-induced reactive airway disease. These patients can have cough that persists for days to weeks after acute illness and they might benefit from bronchodilator or other therapies. Codeine or dextromethorphan hydrochloride has no effect on cough from colds and has potentially limited toxicity. Expectorants such as guaifenesin are not effective antitussive agents. When we see the complications of common cold, the most common complications of cold is acute otitis media, which might be indicated by new onset of fever and earache after the first few days of cold symptoms. Children are at risk for having acute otitis media after cold because one, they have frequent cold attack. Second, they have straight and short Stachian tube. Acute otitis media is reported in 5 to 10% of children who have a cold. And the sinusitis are another complications of common cold. Self-limited sinus inflammation is a part of the pathophysiology of common cold, but up to 2% of viral upper respiratory tract infection in adults and up to 5 to 30% in children are complicated by acute bacterial sinusitis. The diagnosis of bacterial sinusitis should be considered if rhinorrhea or daytime cough persists without improvement for at least 10 to 14 days, if acute symptom worsens over time. For example, if symptoms improve for few days and it becomes aggravated, we should have to consider acute bacterial sinusitis. And the acute signs of more severe signs, such as fever, facial pain, or facial swelling with temperature more than 39 degrees Celsius may suggest acute bacterial sinusitis. Exacerbation of asthma is a potential serious complication of colds. The majority of asthma exacerbation in children are associated with common cold viruses. So rhinovirus is the most common, well-known virus for exacerbation of asthma. There is no evidence that treatment of common cold symptoms prevents acute otitis media, acute bacterial rhinosinusitis, and asthma exacerbation. Although not a complication, another important consequence of common cold is the inappropriate use of antibiotics for this illness and the associated contribution to the problem of increasing antibiotic resistance of pathogenic respiratory bacteria, as well as adverse effects from antibiotics. Thank you for watching.